So 16th question. So we are now moving towards the end of 2017 MCQ. 65-year-old man with 10 pack-year history of smoking presents with confusion and lethargy. Wife complains that he has had a headache, nausea, abdominal pain, a weak back, but no loss of weight and fever. He was dehydrated and disoriented. Calcium levels increased. PTH level is reduced. Serum creatinine level is increased. Sodium level is reduced. Potassium level is mildly increased. Bicarbonate level. ECG shortened QT interval. Chest X-ray mass in the left upper lobe. Which one of the best investigation for identifying the etiology for hypercalcemia? Now, you need to identify that this patient is in a medical emergency, right? Why is this patient in a medical emergency? Can anyone say?
මචං කරා නේද මම ඕක?
නෑ මේක කරේ නෑ. මේක අතහැරලා.
16 පන්න දුකනේ. හරි හරි.
Why is this a medical emergency?
Delirium.
Huh?
It's because he is in delirium.
Yeah, he's in confusion and lethargy, right? And he might collapse, right? That is the problem, dehydrated and disoriented. So he might collapse. So there is something wrong with him, right? There's something wrong. And the problem is his GCS is reducing. If the GCS is reducing, it's a big problem because if it is less than 8, we need airway support. So if there is a patient who is disoriented, right? If there is a disoriented patient, right? Disoriented patient means the patient is not aware of his time, place, person orientation, right? He doesn't know where he is, he doesn't know who he is, and he doesn't know what is in the external environment. In that case, this can be due to the causes, right? Need to be identified and resolved, because otherwise the patient is going to go into some dangerous severe manifestation, right? It can be due to a primary neurological problem, right? It can be due to a primary neurological problem, or it can also be due to a systemic problem. Understood? So if it is a primary neurological problem, some differentials that are present are, one thing, it can be a stroke, it can be intracranial hemorrhage, right? And it can also be meningitis, right? It can be a neurological problem in the brain, or it can be a traumatic brain injury, or a seizure, right? A seizure, status epilepticus can also present like this, right? Those are neurological problems in the nervous system. Systemic reasons for this kind of presentation are circulatory. What are the causes for circulatory reasons that lead to this kind of presentation? Circulatory problems that lead to reduced perfusion of the nervous system, right, which lead to disorientation. So what are the causes for this? You guys already know. One thing is, it can be a myocardial infarction or any cause of cardiogenic shock. It can be a obstructive shock, like for an example, a pulmonary embolism. It can also be septic shock, which is a type of distributive shock, right? And this can also be due to toxins in the circulation. For an example, alcohol will commonly cause this kind of alcohol toxicity can commonly cause this kind of disorientation. And alcohol withdrawal can also cause this kind of symptoms. So alcohol over intoxication and alcohol withdrawal are two different things. Alcohol withdrawal is the state where you get when the patient is not drinking or taking ethanol. His systems that have been already adapted to tolerate that kind of ethanol gets reactivated, overactivated. Alcohol intoxication is when there is increased dose of alcohol ingestion, which causes drowsiness and brain dysfunction. And then this can also be due to inherent toxins. Inherent toxins means the toxins that are produced by the body that are unable to be removed by the body. So this can be something like renal failure. In renal failure, you can get uremic encephalopathy. In liver failure, you can get hepatic encephalopathy. So those are some causes of this, right? So toxins, circulatory problems, and also this can be due to some things like electrolyte imbalances. And out of these electrolyte imbalances, the commonest cause for this kind of disorientation to come about is hypercalcemia, right? There are many other causes also, right? So this can be due to there are many other systemic causes for this kind of presentation, many other causes. So it can be due to something like diabetic ketoacidosis. It can also be due to something like hypoglycemia, right? It can be due to something like HHS, endocrine causes. And then it can also be due to thyrotoxicosis, right? If the patient is disoriented or delirium like patient. And it can also be due to hypothyroid coma, right? So many different reasons for this kind of presentation are already there. Out of that, a common electrolyte imbalance which causes this kind of presentation is hypercalcemia. So when a patient like this presents to you, you first need to identify the priorities. What are the priorities? The priorities are the airway, breathing, circulation, disability, and exposure. Because we need to make the patient stabilized first before we find a cause, right? Stabilization and resuscitation always comes first, and then you have to examine the patient's nervous system. You have to do a relevant systemic examination, and then you have to do the investigations to find the causes for this kind of presentation. Circulatory causes, organ failures, electrolyte imbalances, endocrine causes. Understood? Because this will sometimes come as a SCQ. What are the causes for a drowsy or delirium, disoriented patient or unconscious patient, right? So you have to say what you are going to examine in the examination to find the diagnosis of these likely causes, and what are the investigations you are going to do to find the likely causes for this diagnosis. For an example, if a patient has had a head trauma, he will have features of increase intracranial pressure. One side of the eye, the pupil will be dilated, the other side pupil will be constricted, and the patient will have Cushing's reflex if there is severe intracranial hypertension. And also the patient will have some kind of trauma to the head or a visible skull depression or some bleeding in the scalp that will be suggestive of head trauma. Understood? If there is meningitis, the examination findings will be things like there will be neck rigidity, there will be Brudinsky sign, right? Kernig sign, those things will be positive. The patient will have fever, some purpuric rash, right? And then in the investigations, you will do a full blood count and a blood culture. Never do lumbar puncture in the acute setting, right? And then traumatic brain injury or seizures. In seizures, you will get the clinic books of the patient and identify the patient has had a past history of seizures, and the patient might develop a attack of epilepsy while you're examining the patient, right? So those are the relevant examination findings for each of these differential diagnoses. You have to know the examination findings of the other ones as well, right? So this can be given to you as a SCQ. That is why I mentioned these things. So this patient is having increase in calcium, so it is most likely hypercalcemia. And have you heard of the symptoms of hypercalcemia? In hypercalcemia, there is increased urine passage because of osmotic diuresis, and the patient will have dehydration. That is one symptom they will have, right? And then the next thing they will have, the next complication they will have is that they will also have bone pain, right? Because all this calcium is coming from the bones, so they will have bone pain. And then they will have abdominal pain because of the hypercalcemia. All the muscles in the body goes into spasms, so they will have abdominal pains. And then they will also have they will have urine stones. So urinary stones and calculi formation is also very common with hypercalcemia, right? So what are the causes for hypercalcemia, right? So causes for hypercalcemia can be due to problems in the parathyroid gland. That is one reason that there can be hypercalcemia, right? So hypercalcemia can be due to, right? Hypercalcemia can be due to problems in the parathyroid gland and problems that are not parathyroid related, right? Parathyroid gland related hypercalcemia, and then you can also have non-parathyroid related hypercalcemia, right? So what are the causes of parathyroid gland related hypercalcemia? You can have parathyroid adenomas. So that is an example of primary hyperparathyroidism, right? Understood? There another, and then you can also have increased levels of parathyroid hormone due to reduced calcium levels in the body. So that is an example of uh, kidney disease. However, you can have hypercalcemia due to tertiary parathyroidism also. Tertiary hyperparathyroidism, that is seen in end-stage renal failure. Secondary hyperparathyroidism is seen in early CKD, right? And non-parathyroid related causes are things like malignancies, especially if you think about malignancies that metastasize to the bone, right? Metastasis to the bone, this can lead to hypercalcemia, right? So for an example, malignancies like multiple myeloma, prostate CA, right? Malignancies like if you take it, bone mets, right, can lead to hypercalcemia because it is dissolving all the bone. And what are the other non-parathyroid hormone related causes of hypercalcemia? It can be due to Paget's disease, right? Paget's disease, and also bone mineralization disorders, right? Bone mineralization disorders, where the bone is dissolving, right? So these are the non-parathyroid hormone related causes for hypercalcemia, right? So we'll go into a much more detailed list of causes because we need to know this. This was again repeated in our exam, right? Because of that, this is an important area which we need to discuss, right? Right? එතකොට මේවා තමයි causes තියෙන්නේ ඒවට. හරිද? So the causes of hypercalcemia, it can be due to, as I mentioned, primary hyperparathyroidism, parathyroid hormone related, and also it can be due to tertiary hyperparathyroidism, and it can also be due to parathyroid hormone independent. So one is renal failure, neoplasms, so malignancies, metastasis, multiple myeloma, and also excess vitamin D. Vitamin D can itself cause hypercalcemia. Vitamin D toxins, and then thyrotoxicosis, adrenal insufficiency, right? And there are many other drugs and different things which cause hypercalcemia. But the commonest two types are these, right? So out of these, when this kind of patient presents to us, we have to think about something that is malignant or primary PTH related thing. But the thing is, the parathyroid hormone levels are reduced. So it has to be something that is non-PTH related that is causing the hypercalcemia. And there is a small problem. There is a chest X-ray mass in the left upper lobe. However, he has no history of loss of weight and fever, right? So if this is due to a lump or a mass in the chest, it is very commonly due to a parathyroid hormone related protein dependent, parathyroid hormone related peptide related hypercalcemia, right? So there in malignancies there is something called paraneoplastic syndrome. A lot of malignancies they produce this parathyroid hormone related peptide. So because of this parathyroid hormone related peptide, many cancers produce this. It can very easily produce hypercalcemia because it is like parathyroid hormone but not parathyroid hormone. හරිද? එතකොට parathyroid hormone levels අඩු වෙනවා physiological feedback loop එකකින් හින්දා. But because of the parathyroid hormone like peptide, it is going to cause hypercalcemia. තේරුණාද? So out of these causes, what is going to be the diagnostic investigation to identify the cause for hypercalcemia, right? So what do you think is the cause that is leading to this? What is the best investigation do you think that will be useful in identification of these patients hypercalcemia?
D. Parathyroid hormone binding protein.
Parathyroid hormone binding protein levels, right? Sorry. No, sorry, වැරදුනා. Parathyroid hormone binding protein levels we don't need to do because this is not parathyroid hormone related peptide levels. Those are two different things. Understood, Arna?
Oh, no, what? I got confused.
What are you confused about?
Like you said something is two different thing. I didn't hear that. What?
Yeah, so parathyroid hormone related peptide is a paraneoplastic compound produced by cancers.
Yeah.
You're asking about that here. It is about binding protein level. That is a different compound.
Oh, okay.
So not the same, right? If this was parathyroid hormone related peptide, it would have been correct.
Okay.
Okay. So this patient has a chest X-ray mass in the left upper lobe. So it looks like malignancy for me, right? So the most usual diagnosis which I will do is a skeletal survey to check whether the patient has bone mets. Because as you know, bone malignancy can be very well, lung malignancy can very well metastasize to bone. So for me, I think the best answer is skeletal survey. But then if you are suspecting something like multiple myeloma, you can also do plasma electrophoresis, right? So I think for at the moment, these two are the best investigations to find a cause. What do you guys think? Any questions regarding how we diagnosed it? Oh, right. Jaharna, understood? Hello.
Yeah, I understood. I didn't on the mic and I was telling yes.
Okay, so we have now covered that part. What I want you to identify is there are two different causes for hypercalcemia. One is parathyroid hormone related and non-parathyroid hormone related ones. In parathyroid hormone related causes, PTH levels will be elevated. In non-parathyroid hormone related causes, PTH level will be low. Understood?
Yeah.
Okay, so next we go into this one. Which of the following favors a diagnosis of rheumatoid arthritis, right? So when it comes to rheumatoid arthritis is a inflammatory arthritis. It's a symmetrical polyarthritis that involves usually the upper limbs, small joints, small peripheral joints, symmetrical polyarthritis, right? Rheumatoid arthritis is diagnosed by clinical diagnosis, right? There are no criteria to diagnose rheumatoid arthritis, right? However, there are different criteria that are created for just identification of different patient subgroups, right? Those are called classification criteria, not diagnostic criteria. For rheumatoid arthritis also, you have this kind of criteria for classification. Does anyone know the name of this criteria for rheumatoid arthritis classification?
EUS, no. AUS Asler, Euler, something.
ACR Euler criteria.
Yeah, ACR.
Do you know the year?
I don't know the year.
Remember, it is 2019 ACR Euler criteria, right? So
Okay.
go and refer this, because this shows all the diagnostic points that the patient must have or might have if you are suspecting rheumatoid arthritis. Understood?
Okay.
Right. So if you think about the causes now, this is SBA, chalk like thickening over toes. This is not
Mm-hmm.
seen in rheumatoid arthritis. Erythematous rash across the bridge of the nose and cheeks, sparing the nasolabial. This is also not a classical feature of rheumatoid arthritis. Does anyone know where you see this rash?
Erythematous rash across psoriatic.
අර
SLE.
බටර්ෆ්ලයි එක නේද?
Yeah, this is the butterfly rash in SLE. Right? You need to know. And then skin thickening, small mouth and bird beak appearance. Small mouth is technically called microstomia. Right? Microstomia. You can patient cut like that, you can't put the 3 fingers in, right? That is called microstomia, bird beak appearance, and skin thickening. What is that called? And also, this patient will have features like sclerodactyly, and then also they will have shoal sign or skin hypopigmentation around the neck. What disease causes this kind of presentation? Hello? What rheumatological disease causes this kind of presentation? Systemic sclerosis. හරිද? Scleroderma කියලා එකක් අහලා තියෙනව නේද? This is false. ඒක අහලා තියෙනවද? Hello?
ඒක බලන්න ඕන බං ඒක තමයි.
Right. ඒකේ නම
කොටස් දෙක තමයි.
short case වල අහන්නේ නෑ ලොකුවට. ඒනට ඔයාට ස්කෝර් කරන්න පුළුවන් interstitial lung disease වල course එකක්. If the patient has these features, you can identify the patient as scleroderma, right? ඒක කිව්වොත් හොඳයි ඉතින් exam එකේ. ඒක බලා ගන්න. ඒකේ features ටික තියෙනවා. දැක්ක ගමන් identify කරගන්න පුළුවන් patient කෙනෙක්. Nail pitting and nail tip changes. What disease cause this? Thimble pitting. This is called thimble pitting of the nails. Where do you get this kind of manifestation? Jeshabandhu?
Psoriasis වගේ case.
Yes, this is seen in psoriasis. So this is also not a part of rheumatoid arthritis. So psoriasis is not inflammatory arthritis, right? Sorry, seropositive rheumatoid arthritis and psoriasis are two different things. And then you can also get a rash in psoriatic arthritis, the characteristic plaque-like rash. It is a subcutaneous nodules on extensive surfaces of arms and hands. Make a hadida. Oh, anything I think. This is rheumatoid nodules, right? So rheumatoid nodules are seen in rheumatoid arthritis. And
rheumatic rheumatic fever එකේදී අර මේ කියන්නේ pediatrics එකේදී Jones එකේ
ඒක
වෙනස්.
වෙනස්.
ඒක මොකද බං? ඔව්.
ඒ nodule එක එන තැන සමානයි, but the cause is different. This is due to arthritis. Rheumatic fever is due to a molecular mimicry.
Yeah.
Right? So this rheumatoid nodules in rheumatoid arthritis is a poor prognostic sign of rheumatoid arthritis. ඒක හොඳට මතක තියාගන්න. When they have rheumatoid nodules, the disease is very, very active, severe. Okay. So we go to the next one. At least now you have a lot of rheumatological diseases now. For medicine, right? Medicine walata learn about these two rheumatological diseases, right? SLE and rheumatoid arthritis in detail. So you need to know regarding these rheumatological causes, how you diagnose the condition, the classical presentations of this disease, the examination findings of a patient with these diseases, the pharmacological treatment that you do for these patients, the non-pharmacological treatment that you do for these patients, and also the lifestyle advice that you give for these patients. And in the presentations, you also need to learn about the complications of these rheumatological diseases. Understood?
Okay.
Right? For SLE and rheumatoid arthritis only at your level. Understood? So we go to the next one. 35-year-old man presenting with history of cough, weight loss, and night sweats. 3 early morning sputum samples are negative for acid-fast bacilli. What is the next best investigation to confirm the diagnosis of pulmonary tuberculosis? Confirm the diagnosis. The confirmation, best investigation is a culture, right? Gene expert is not the best investigation to confirm, right? This is the gold standard investigation to confirm the diagnosis. Understood?
Okay. What is the gene expert then?
That is also for a diagnosis, but if you are now here, they are asking for a best investigation, the best investigation. That is, of course, culture.
Okay.
And also, now something that I just wanted to say, ADA levels, ADA test is also something which you do to diagnose TB, right? Especially to diagnose TB in a pleural effusion sample, you need to do the serum ADA levels. Understood?
Okay.
We go to the next one. A 30-year-old female presents with chronic cough and shortness of breath for 6 weeks. Cough is dry, scanty mucoid sputum. She also complains of mild fever and she is generally unwell. She is on immunosuppressive drugs for SLE with class 3 lupus nephritis. So she's an immunocompromised patient, right? On examination, she is breathless. Respiratory rate is 26. Auscultation is normal except for fine crepitations. CRP levels are sky high, right? And then WBC levels are low, neutropenia. Bilateral patchy infiltrates in the middle zones. What is the most likely diagnosis? So there is neutropenia, right? So do you guys identify that this patient has an infection?
Yeah.
Why? CRP levels are very high.
CRP.
Very high. And then yeah.
And she is also having fever and she is generally unwell, right? So what sort of pneumonia is this? Depending on the patient characteristics. Lobar, I won't say it's lobar because this shows bilateral patchy infiltrates. මෙහෙම නම් අපි කිව්වේ මොන වගේ pneumonia?
Diffuse.
Yeah, what is the lobar? Broncho. Excellent. So this is bronchopneumonia. Remember our respiratory short cases. Now you have to remember these. Huh? Next week, if you don't know, something will happen either. So there are different types of pneumonia, right? You need to know this. Pneumonia types are, the first one is community acquired pneumonia, which is seen in patients coming from the community. So the patient, if you talk about his history for the last 48 hours to 6 weeks period, he has not been in a hospital. He is coming from his home. Understood?
Yeah.
This is called community acquired pneumonia. And then you have hospital acquired pneumonia, which is when the patient has at least 48 hours of hospital exposure in the past 6 weeks. And then you have something called VAP, ventilator associated pneumonia, which is seen in ventilated, intubated and ventilated patients. And then you also have another type of pneumonia, which is called pneumonia of immunocompromised patients, which is seen in immunocompromised individuals. So what sort of pneumonia do you think this patient has?
Immunocompromised.
Yes, this is the pneumonia of the immunocompromised. So here, to get the answer, you need to know theory. Usually, patients who are on immunosuppressants, specifically for CKD, renal transplants, and also lupus nephritis, very commonly get pneumocystis jirovecii pneumonia. Understood? So even if you didn't know that, out of the answers, right? If you think about the answers, these three are always due to fibrosis. So you can remove those. And if you think about the pneumonia types, right? This patient is from the community, but she's a special individual because she's immunocompromised. So the only pneumonia for the immunocompromised given here is pneumocystic cerevisial pneumonia. So even if you didn't know that these patients with renal transplant and renal immunosuppression are very common to get pneumocystis cerevisial pneumonia, you can still work it out if you are cunning and understand the theory. Understood? Okay. So you might know that this pneumocystis cerevisial pneumonia is also very common in HIV/AIDS patients, right? And usually these patients receive daily co-trimoxazole for prophylaxis, right? Daily co-trimoxazole prophylaxis for pneumocystis cerevisial pneumonia. That is just the additional point I mentioned. They might give you this as a next as a point next year, right, in the exam. So this might come in handy. So when you are answering MCQs, be very methodical. Use your theory from the past. You already know the most important theory parts, right? You have learned for 6 years now, so you already know the most important theory parts. So use that theory to come to a diagnosis. This won't be very hard things they will ask in the exam. You just need to take time, think it through, and give an answer.
Yeah.
I'm looking for a screenshot that I took from the internet that has all the pneumonia types and the features that you see in each of the pneumonia types given. I will quickly look for it and send it. So then you guys can study every pneumonia in one go. A few minutes. Can you see? So all the pneumonia types are given here, the important ones. So from the clinical history itself, sometimes you can suspect the organism. If the patient has had cold sores and also is having rusty colored sputum, the patient is most likely, if the patient is coming from the community, the commonest organism to cause community-acquired pneumonia is strep pneumonia, right? And then if the patient is having flu-like symptoms, he's an IV drug user, and he might also have features of infective endocarditis. Then the commonest organism that is causing the pneumonia or the lung infection is Staphylococcus aureus, right? So Staphylococcus aureus pneumonia can have coinciding incident with infective endocarditis also. Remember, alcoholics and diabetics usually they get alcoholics specifically they get Klebsiella pneumonia and even lung abscess because they aspirate oral secretions, right? So because of the aspiration of oral secretions, the commonest organisms to cause pneumonia in alcoholics is Klebsiella pneumonia. Understood? And then if the patient is having hyponatremia, reduced sodium levels, the commonest organism to cause that pneumonia is Legionella pneumonia. And then if the patient is coming from a very congested area and having hemolytic anemia, this comes into play especially in pediatrics. And I think we also discussed a MCQ regarding this. I can't remember whether it was in pediatric or medicine, but if the patient is having pneumonia with hemolytic anemia, most likely due to mycoplasma pneumonia. If the patient is having exercise-induced desaturation, history of HIV is there, pneumocystic cerevisial pneumonia. This patient has a history of exercise-induced desaturation also. Can you remember? Right? So those are the pneumonia types. So remember these things. Huh? MCQ points. So we go to the next one. A 25-year-old nursing officer presented with self-poisoning with dilated pupils, agitated, restless, drowsy with urinary retention. Blood pressure is 110/65, pulse rate is 120 beats per minute, lungs clear, ECG shows sinus rhythm with broad complexes. So this is broad complexes means it can only be due to two causes. Either it is ventricular tachycardia or ventricular fibrillation. Because the patient has a sinus rhythm, this has to be ventricular tachycardia. Understood? So ventricular tachycardia with these features of dilated pupils, agitation, restless, drowsy with urinary retention. So he's having sympathetic symptoms, sympathomimetic symptoms, and then he's also having features like urinary retention. So there is parasympathetic action, parasympathomimetic actions also. So there's a combination like this. So what do you think is the likely poisoning here?
නර්සින් ඔෆිසර් කෙනෙකුත් තියෙන හින්දා බං මොකක් ඩ්‍රග් එකක් වගේ එකක්.
Yeah, of course it is a drug.
Tricyclic.
Yes. So this is due to tricyclic antidepressant toxicity, right? And when there is tricyclic antidepressant toxicity, there is only one indication where you give IVs. The main indication in tricyclic antidepressant toxicity, the antidote for tricyclic antidepressant toxicity is IV sodium bicarbonate. Right? So the answer here is sodium bicarbonate. This is something you need to know, right? You can't use theory, or you can't use logical arguments to come to an answer here, right? So IV sodium bicarbonate is given in only a few indications. One indication is when the patient is having metabolic acidosis, right? Metabolic acidosis and refractory shock, right? That is one indication where they give IV sodium bicarbonate. And then another indication they give IV sodium bicarbonate is as an antidote, right? As an antidote to tricyclic antidepressant toxicity. Understood? So these are the only two indications they give IV sodium bicarbonate, and this refractory shock with metabolic acidosis should also be there in Dengue shock syndrome. ඒකේ තියෙනකොට තමයි දෙන්නේ IV sodium bicarbonate. මේ දෙක විතරයි IV sodium bicarbonate දෙන්න තියෙන එකම indications. වෙන කිසිම metabolic acidosis type එකකට you don't give IV sodium bicarbonate. තේරෙනවද? So we go to the next one. 48-year-old man was found unconscious on the road and brought to the hospital by passengers. He was able to localize pain with afferent pupillary defect. So he is blind. Investigation results are as follows. pH is reduced. Bicarbonate levels reduced. Lactate increased. Osmolality increased. What is the normal osmolality of blood? Hello?
No, don't know.
You need to know this, huh? 285 milliosmol per liter. So this is very high. And the patient is also blind. And what sort of acidosis is this? They have not given CO2 levels.
Yeah. Metabolic?
Looks like metabolic acidosis, no?
Yeah.
So what is the most common cause of this poisoning? Cassipobila, right? We found a similar case in early MCQ, remember? Come, they all repeated. If you know the MCQs and the answers and the logical reasoning behind those MCQs, you can definitely score more than 50% for the MCQs, right? That is the secret. You have to identify the theory chunks which are commonly asked in the MCQs, and now we have already discussed more than 60-70% of them. So if you go through our discussions very slowly and carefully and identify and study the homework which I give you and pay attention in our discussions, you can definitely right now, even if you take the medicine MCQ, you will pass, right? So which of the following can cause this methanol poisoning? What is the antidote for methanol poisoning? Ethanol. What is the other antidote or treatment which we can do to relieve a patient with methanol poisoning? What is the other thing which we can do to these patients? Giving ethanol, and what else? We discussed these things. If you can't remember, this is your fault. Hemodialysis. What are the indications for hemodialysis in methanol poisoning? Refractory acidosis. What else? Blindness. So this patient will likely need hemodialysis, right? Understood. There another. Okay, so we go to the next one. 65-year-old farmer was bitten by a snake while sleeping in a shed. Right? At 8 p.m., he developed pain and local swelling at the bite side. He had difficulty opening eyes and diplopia. Whole blood test was positive. What is the snake? So, what are the manifestations this farmer is having?
Pain.
What are the manifestations he is having?
Local.
Local.
Yeah, local pathology is there, neurological symptoms are there, and then hematological symptoms are also there. So, what is the likely snake that has bitten him?
Russell's.
Yeah, Russell's. Russell's is the only viper or the only snake that has all three manifestations, right? And this viper will also lead to renal failure, right? So, අපි අනිත් කට්ටියගේ manifestations කිව්වොත් what are the manifestations of common trait? Ale? Any local manifestations? Any problems with blood clotting? Okay. Cobra? Local manifestations? What else? Neuro. Right. What about hump nose? Yes. Local manifestations, AKI and clotting. Right. What about this guy, Soske? Jarno?
Huh?
Huh?
I don't know.
Should you know? Should you know this?
Yeah, right.
Yeah. So is it your fault or my fault that you don't know this?
My fault.
Okay, then better go and refer this today. Okay?
Okay.
There's a chart in the guideline. Man guideline එක දැම්මද group එකේ? දාන්න ඇති. අනේ මම දැම්මම guideline එක. Did I put the guideline?
Not to my knowledge. I didn't see. Recently?
යරණ හිටියේ නෑ නේද?
Okay. The guideline
ඔකම
is
14
not
එකේ
there.
තිබ්බනේ.
Huh?
අනේ අන්තිමටම කරපු එකේ. අන්තිමටම කරපු එකේ අන්තිම ප්‍රශ්නේ තිබ්බේක. මේ මීට
ඒක
කලින්
මම
කරපු
guideline
එක.
එක දැම්මේ නැද්ද?
No, guideline is not there after I
නෑ
joined.
නේද?
Okay, but I put that photo, ne? I put the photo. Okay, I'll just put the guideline now itself. Right? Don't read the whole guideline. I already gave you the overview of poisoning with snakes in the last MCQ. I'm not going to do it now. I will never do it again also, because I took like 1 hour and did the session on snake bite. I think I have given the note in annotated note also. So just refer the small table there in the guideline, right? Understood? So what is the importance of knowing the snake? Now, anyways, to all the snakes, we have to give the same antivenom. What is the importance of knowing the snake? In our management? Ale? Why? That is one thing. What are the snakes which we don't give antivenom for? Okay. What is the other reason? Hmm. And then what else? What is the other importance of knowing the snake?
The time period, like taken to form the complication.
Yes, to expect the complications, right? So I know if the patient is likely to be bitten by some snake like common trait, there is a high risk the patient will develop respiratory complications, neurological complications. So in the examination, I am specifically focusing on that when I am examining and monitoring the patient. Understood?
Okay.
And then what is the other importance? For Russell's viper, we can give second double dose of antibiotic. Understood?
Mm.
Okay. So we'll leave this one because this is MCQ that it has no good, right? So we go to the next one. Hemoglobin level dispersion of females in the state sector showed a skewed distribution. What is the best method to evaluate this distribution? So, in studying biological parameters, now biological parameters are different parameters in the population of humans. There can be symmetrical distribution. This is called a normal distribution, right? Normal distribution, or there can be skewed distribution. So skewed distributions are distributions like this, right? So in a normal distribution, the best method to evaluate dispersion is standard deviation, right? But in a skewed distribution, it is very hard to assess for the dispersion by standard deviation. So there, of course, you have to go for another method where you assess the dispersion, right? And dispersion can be assessed by interquartile range, uh, and then range and also variance, right? Out of these, what is the best method to identify the dispersion? If I can remember right, this is variance, right? You put a check. Okay, variance name. The best method is interquartile range. So that you have to know as a theory, right? And
Mm.
then we go into the next two.
Oh.
A 50-year-old man experienced gradually progressive shortness of breath with a rash. A generalized pruritus few minutes after antibiotic infusion. SpO2 is 88% with pulse rate of 110 and blood pressure of 80 by 50. What is the immediate next step of management? What is the condition the patient is having?
Anaphylaxis.
Why do you say so?
Because he had, yes, after antibiotic infusion, he got it.
Exposure to a known or identified agent, and then what else?
And the signs, he
Yeah,
had
SOB with rash.
a survey.
2 or more systems involved. So there is cutaneous system, and then respiratory system, and also circulatory system.
Yeah.
And then when there is shock, what do you call this? Or reduced blood pressure or hypoperfusion? What do you call this? This is anaphylaxis. When there is shock.
Anaphylactic shock.
Yeah, excellent. So there is anaphylactic shock, right? So what do you do in anaphylactic shock?
Give adrenaline.
What adrenaline?
IM 0.5.
Okay. What's concentration?
1 in 1,000.
Where in the body do you give it to?
Anterolateral aspect of the thigh.
Anterolateral mid-thigh, yeah?
Mm.
We go to the last MCQ. 5-year-old female presents with headache, blurred vision, and vomiting. So these are features of what? Headache, blurred vision, and vomiting.
Increase intracranial pressure.
Intracranial.
He had papilledema. MRI, no ischemic or mass lesions. LB showed high pressure. So what is this condition? Corning is a complication. This patient is not having corning. What is the disease that she is having? මේක නමක් තියෙනවා මතක තියෙන benign intracranial hypertension කියලා. හරිද? It is a diagnosis of exclusion. When no other cause for this increased intracranial pressure can be identified, this diagnosis is made. And the treatment, the first line treatment that you give for it is, remember, acetozolamide. හරිද? Carbonic anhydrase inhibitor. Argument.
Yeah.
What is metolazone? Hello, what is metolazone?
Oh, it is.
It is a thiazide diuretic.
Is that? Yeah.
Right? So you give carbonic anhydrase inhibitors as a treatment for benign intracranial hypertension. Just know it as a point. Now there are, in the MCQ paper, there are some MCQs which is very hard to get a mark for. If you don't know the theory, you get it. If you don't know, you don't get it. So if I was attempting this MCQ for the first time, I will not get marks for these MCQs, but I will be okay with that, right? Because these are SBS, no, so you anyway have to have a answer for them. Even if you don't have, you have to choose something and do tactic to can choose one, right? So that is the theory and the beauty of MCQs. You can't get everything, but there are majority of MCQs which you can of course get. So anyone with the sound knowledge will be able to get about 80 to 90 marks here, but it will be very hard to get 100. I don't think even the person who made it can get 100, right? Because no one person makes this, no, so different people come together and they make the MCQ, right?
Yeah.
So that's the normal thing about MCQs, and that is the same with life. You can't have everything, so you have to choose wisely what you want, right? Something that we missed, we'll go into this MCQ now. A 31-year-old woman presents with 1 year history of red erythematous scaly rash. What is the feature more suggestive of eczema than psoriasis? So red erythematous scaly rash can be due to either eczema or it can be due to psoriasis, right? What are the types of eczema, you know? Atopic eczema. Any other types of eczema, you know?
Dermatitis.
Huh?
Dermatitis.
Allergic dermatitis. Any other things you know? Have you heard of this condition called seborrheic dermatitis? So these are different causes that cause inflammation of the skin. Out of that, if it is due to allergic cause or atopic cause, where the patient gets inflammation of the skin without even a known trigger, that is called atopic eczema, right? So we'll go into the features that are more suggestive of eczema. Eczema has well demarcated lesions. True or false? Compared to psoriasis?
True.
False. Eczema does not have well demarcated lesions. Plaque psoriasis, the plaques are very clearly demarcated. So this is false. Lesions located in flexures than extensors. True or false? True. Right? Nodules are seen in eczema. True, but nodules are also seen in psoriasis. So this is false. You can get pustular psoriasis, where you get pustular nodules in psoriasis, right? So psoriasis also have different types. What are the types of psoriasis? You guys know? One thing is pustular psoriasis. Ekedi infections again, nikak pus, psoriasis wala plaques ikta. Scalp psoriasis is one type. Any other types? මාත් ඔය දෙක තමයි ගන්න බලමු අනිත් තව ඒවා තියෙනවද කියලා. Yeah, so there are different types. So erythrodermal psoriasis, guttate psoriasis, ඒ වගේ කියලා එක එක තැන් අනුව scalp psoriasis, ඒ වගේ depending on the location and the features, there are different types of psoriasis. හරිද? Guttate psoriasis and so on. And then they also have nail psoriasis, right? They also have nail psoriasis. And then eczema increases in cold weather. True or false? This is true. Eczema does increase in cold weather, but does psoriasis increase in cold weather?
Maybe.
Yeah. So both increase. So this is false. The history of distal interphalangeal joint pain and swelling. This is seen in psoriasis or eczema? Psoriasis. So this is false, not a feature of eczema. So the main feature which we can identify to differentiate is, for me, I think it is lesions localized in flexures and extensors. So that is the MCQ of 2017. So we finished the 2017 MCQ. More than finishing an MCQ, what is most important is you guys know the theory behind getting each and every answer, right? That is the most important thing. So I have given you homework each and every day to refer after our session. So I hope you refer. අපි 2017 paper එක කරාද people